Master USMLE Podcast, Brain Death and Critical ICU Concepts. Welcome back to Master USMLE, where we break down high-yield USMLE topics in a way that makes sense for the exam and real-world practice. Today, we're focusing on brain death, but we're also going to connect it with other key ICU concepts that are frequently tested on Step 2 CK. Case Scenario: ICU and Brain Death Evaluation. You're called to the ICU to evaluate a 45-year-old man who suffered a severe head injury after a motorcycle accident. He's been on a ventilator for the past 48 hours, with no signs of responsiveness. His pupils are fixed and dilated, there's no corneal reflex, and cold water irrigation in the ear produces no eye movement. He doesn't respond to pain, and the team is considering a brain death exam. The question is, what findings are still possible in brain death? The key one? Deep tendon reflexes. Even in brain death, spinal cord activity may still be intact, so reflexes like the knee jerk may still be present. But anything controlled by the brainstem, like the pupillary reflex, oculovestibular reflex, gag reflex, or spontaneous breathing, must be absent. To confirm brain death, the apnea test is performed. The patient is taken off the ventilator, while CO2 is allowed to rise above 60 millimeters of mercury. If there's no spontaneous breathing, brainstem function is gone, confirming brain death. If the patient makes an effort to breathe, then they are not brain dead, because the medullary respiratory centers are still intact. Merging ICU topics for Step 2 CK. Let's take this scenario and build on it, because Step 2 CK loves to test related critical care concepts. Brain death versus coma versus persistent vegetative state. Brain death is irreversible. This patient is legally dead. But what if a similar patient is in a coma or a vegetative state? Coma. The patient is unresponsive, but brainstem reflexes are still present. They may improve, remain in a vegetative state, or deteriorate. Persistent vegetative state. The patient appears awake, has sleep-wake cycles, but lacks awareness of self or environment. Unlike brain death, basic reflexes and autonomic functions persist. Step 2 often asks you to differentiate these three conditions, so make sure you focus on brainstem reflexes and breathing patterns. Neurogenic shock versus spinal shock. Classic trauma questions. Now let's say the same motorcycle accident patient had a cervical spinal cord injury instead of brain death. The exam might ask, are they in neurogenic shock or spinal shock? Neurogenic shock happens when there's a loss of sympathetic tone due to severe spinal cord injury. Key signs: bradycardia, hypotension, and warm skin due to unopposed vagal stimulation. Treatment: IV fluids plus vasopressors, norepinephrine, to restore vascular tone. Spinal shock is different. It's the temporary loss of reflexes and muscle tone below the injury due to disrupted spinal pathways. Key signs: flaccid paralysis and areflexia immediately after injury. Reflexes return gradually over weeks, sometimes leading to spasticity. Step 2. CK loves this comparison. Neurogenic shock is hemodynamic, loss of BP and HR control, while spinal shock is purely neurological, temporary loss of reflexes. Key takeaways for Step 2. CK check brain death equals no brainstem reflexes, no breathing response, but DTRS may persist. Apnea test confirms brain death if no respiratory effort when CO2 greater than 60 millimeters of mercury. Neurogenic shock, jar hypotension, plus bradycardia, loss of sympathetic tone. Spinal shock, siren, flaccid paralysis, plus areflexia, temporary loss of reflexes below the injury. Coma versus vegetative state equals brainstem reflexes intact in coma. Vegetative state has sleep-wake cycles. Understanding these ICU concepts not only helps on the exam, but is also crucial in real-life patient management. That's it for today. Keep studying, stay focused, and master the USMLE.